coastal and intercoastal.
What happened to the respiratory effort here? Respiratory effort increase. You can see the increased respiratory effort. Okay, refractance, different cyanosis in the baby, and this is the feature of high-level disease. Okay, high-level disease, very important. Okay, now a mother is coming to you. Okay, the mother is coming to you and asking you, my child. Okay, my child previously had high-level disease. This is my second child. Okay, I have a doubt whether this baby also will develop high-level disease or not. Okay, so what you are going to do is you are going to advise the patient to undergo certain tests. Okay, so what is the first test we can take this? We can go for lamellar body count. Lamellar body count. Okay, what is this lamellar body count? Okay, what is this lamellar cells? Are storage body for surfactant. Okay, at 20 weeks of gestation. Okay, if there is an increase in the lamellar count, they don't have any definite numbers. Okay, increased lamellar count is present, then it means that lung maturity present. Okay, then the second thing is we are going to see for this is the sphingomyelin ratio. This is the sphingomyelin ratio. Okay, when usually at around 20 weeks of gestation, the lecithin level increases. Okay, whenever your NS ratio is more than 2, then it means lung maturity is present. Okay, then the third thing what you can do is you can measure the activity of phosphatidyl glycerol or choline. Okay, this usually done at around 35 weeks of gestation age. Okay, gestation age. Okay, so how you are going to do this? Okay, what you are going to do is you are going to take the amniotic fluid, okay, and put it in a test tube. Okay, and what it contains protein. Okay, when it has protein, when you shake the protein, what will happen? It will form bubbles. Okay, so bubbles if present, okay, then lung maturity is present. Okay, bubbles is present, then lung maturity is present, and this is done by a test called shade test. Okay, shade test. So shade test is a subjective test where you take the amniotic fluid, put it in a test tube and shake the test tube, and you can see the bubbles like this. Okay, bubbles like this. Okay, so this is called a shade test. I will show you the shade test. So this is a test tube, okay, where you take the amniotic fluid, shake it well, and after getting water out, there will be bubbles better. Okay, if bubbles is present, then lung maturity is present. If there is no bubbles, then it means that lung maturity is negative. Okay, lung maturity is not present. Okay, imagine now a baby is coming to you, born baby is coming to you, okay, and you do a shade test, and shade test is negative. Okay, and what you are going to do now? You are going to deliver because baby is in hypoxia. The mother is having preeclampsia. Okay, you have to deliver the baby. Okay, so at or less than 34 weeks of gestation, okay, so your baby from inside is singing one song. Okay, what song it is singing? Daddy, daddy, oh my daddy. Okay, it is singing. Okay, and you want your beta intact. So what you are going to do? When you want your beta intact, then you have to give betamethasone. Okay, so you have to go betamethasone, which is more drug of choice than dexamethasone. Okay, so when you want your data in health, you have to go for beta-interferon. Okay, beta-interferon. Because I told you steroids are stimulators of surfactant production. Okay, so you go for steroids. Okay, in the form of beta-interferon. Okay, now your baby is delivered. Okay, the baby is delivered. So when the baby is delivered, okay, baby is delivered now. Okay, and baby is having respiratory distress. Okay, so what scale you are using? So you are checking for Apgar scale score, and what is under scale? This was one famous initial question, right? In pediatrics. Silverman scale. Okay, so both scales are checking and baby is having distress. Okay, so whenever you check and it distresses mind, okay, what you're going to do is you're going to put the baby on CPAP. Okay, if the distress is mild, you're going to put the baby on CPAP. Okay, whenever it is moderate to severe, moderate to severe. Okay, the treatment what we are going to do is surfactant replacement. Surfactant replacement. Okay, so replacement. So how the surfactant is replaced? By a technique called, if you want to ensure the baby intact, you go for ensure technique. Okay, so what is ensure technique is, you intubate the child, okay, and then you give surfactant, and once the child recovers, extubate. Okay, so what is the surfactant which we are usually using? Okay, so when you go to pediatric question, they will tell that gives what is surfactant. Okay, we have two surfactants here. One is going to be luminactant. The other one is going to be baractant. Luminactant and baractant. Okay, so these are the two surfactants which are available for ensure technique. Where you integrate the surfactant distillation followed by distribution. Okay, surfactant distillation through the leading surfactant. Okay, then you are going to distribute the baby, and this is called the ensure technique. Okay, ensure technique. Okay, so what are the markers? This was last year initial question for the completion sake we are taking. What are the markers of alveolar cell maturation? Okay, so if you take, there are two markers for type 1 and type 2 alveolar cells or pneumocytes. Okay, for type 1 alveolar cells, we are going to have caveolin, which is going to be a marker, aquaporin 5, which is going to be a marker, and carboxypeptidase, which is going to be a marker. Okay, coming to type 2 alveolar cells. Type 2 alveolar cells, we have surfactant protein A, B, C, and A. Okay, a common marker for both type 1 and type 2 alveolar cells is going to be, it is a common marker for both surfactant production and for type 1 alveolar cells, which is going to be this. Okay, so these are a few things which is very important things about the anatomy part of your respiratory medicine. Okay, and the technique what you are following is called the ensure technique in patients with HFD, where you intubate, use surfactant and go for extubation. Okay, extubation. Okay, so this is about your anatomy part of your pulmonology, and this is very important because we are in various areas we are going to use this things. Okay, and before completing, just for completion sake, I will go into another one. What is Charles syndrome? Charles syndrome is one way the patient is going to have C for coloboma of radius, H for heart disease, A for atresia of quinine, okay, atresia of nose, okay, and patient has retarded growth, genital anomalies, and ear anomalies, okay. Here, if you see the eye of the baby, will have quinine atresia. Why am I telling this? Telling this here. The patient is maybe going to have quinine atresia, okay, quinine atresia. When the patient has quinine atresia, okay, what is going to happen? The quinine is atresia, okay. Now patient is breathing in and breathing out. Whether the patient child will be able to get air inside? No, okay. So at that time the patient will be having cyanosis, okay. Now baby starts crying. When baby starts crying, it will open the mouth and cry. No air goes inside. What will happen to the cyanosis? Improves. Okay, so this is called the cyclical cyanosis. Okay, cyclical cyanosis, where it is going to be during the baby being silent, there is no cyanosis. When the baby starts crying, there is an improvement. Whenever baby is still, there is cyanosis is present. When the baby starts crying, cyanosis will disappear. Okay, what is the bedside test to assess quinine atresia? Okay, you just take a rice tube, put inside. Rice tube, there will be resistance of putting the rice tube. Okay, and how to confirm it? You have to go for HRCT. Okay, in HRCT you can see a membrane over the posterior quinine, posterior quinine. Okay, so this is more of a pediatric and anatomy question just for completion sake. Okay, so this is very important. And one more question which was asked in PGI once, where one lung is very big, okay, one lung is very big and another lung is little smaller, okay, and that is called as McLeod syndrome or Swyer-James syndrome, okay, again pediatric, okay. So in congenital anomaly, one lung is hypervisual, okay, another lung is comparatively small, okay. So this kind of discrepancy is seen in McLeod syndrome or Swyer-James syndrome, okay, McLeod syndrome or Swyer-James syndrome, okay, again a pediatric question, okay, pediatric question, okay. So there are a lot of another anomalies in Schmitter syndrome, okay. Schmitter syndrome is again an anomaly where you will have anomalous pulmonary vein, okay, that is seen in again malformations of the development of lung, okay. So these things are again the pediatric part and anatomy part, so those parts are not touching, okay, those parts are not touching. So few things in anatomy with respect to pulmonary medicine you have to read. One is Schmitter syndrome, okay. Another is another important thing is called lobar lung, okay, lobar lung, okay. So what is lobar lung is you will have a lung and separately you will have another one lobe, okay, which gets a separate blood supply, okay, that is called as lobar sequestration or lobar, okay. So again there is going to be anatomy, okay, so I'm not touching it, okay, I'm not touching it. So with this we finished the anatomy part of respiratory medicine, okay. From here we are going to the next part, which is going to be your physiology part of respiratory medicine, where important is investigation, which is going to be your spirometry. Okay, so we'll go for a break, and after break again we will start with spirometry, which is very important for your exam.
Okay, so we'll go into the next discussion, okay, which is going to be spirometry. Okay, spirometry. So pulmonary function test and spirometry. So whenever you take your lung, the lung usually inhales and exhales, okay. So the air goes inside the lungs and comes out of the lungs, okay, like this. So air goes inside and comes out of the lung, okay, and this lung can be obstructed or restricted in two areas, okay. So the lung can be obstructed in the airway, which prevents the air going inside and coming out, or the lung can be restricted from expanding, okay. So we have two types of lung diseases where there is a airway resistance causing obstructive lung disease, or decreased compliance or expansion of the lung resulting in restrictive lung disease. So these are the two types of lung diseases we have. And if you take gaseous exchange, it occurs in such a way that air every time goes inside and comes out of the lung. Okay, air goes inside the lung and comes out of the lung. Okay, whenever there is some problem in this, then what is going to happen? There is going to be change in the lung volume. Okay, so now coming to pulmonary function test, every time, every day you breathe in and breathe out without your knowledge, which is going to be tidal volume, which is called as tidal volume. Okay, tidal volume is the air which you are breathing in and breathing out every time, every day without your knowledge. Okay, on top of tidal volume, you take a deep inspiration, and that is going to be called as inspiratory reserve volume. Inspiratory reserve volume. After deep inspiration, your lung is like a elastic balloon. Okay, so when you expand it this much, what is going to happen? It will recoil back. Okay, so even though this process where I'm going to pull this balloon like this is an active process, but what is going to happen? There is going to be recoil, which is going to be a passive process. Okay, this passive process does not require energy, but whenever it is a passive process, what is going to happen is there is going to be, you are taking a deep inspiration followed by a expiration, where because of the passive process, some amount of air will go out of the lung and some amount of air is going to retain back in your lung. Okay, the air which goes out of your lung is called as expiratory reserve volume, and the air which is going to get retained in your lung as a residue is going to be called as residual volume. Okay, residual volume. So every time you breathe in and breathe out, this is going to happen. Okay, tidal volume is defined as the amount of air entering in and gets out of lung, which is happening without your knowledge. Okay, and this is going to be around 500 ml. Okay, which is going to be around 500 ml. Inspiratory reserve volume is defined as the amount of air entering in addition to tidal volume. Okay, so this is going to be 3100 ml. Okay, then next is expiratory reserve volume. Okay, expiratory reserve volume is amount of air expired in addition to tidal volume. Okay, so it is going to be somewhere around 1200 ml. Okay, residual volume is the amount of air retained in lung, which is going to be 1200 ml. Okay, so these are the 4 important volumes you have to know. Okay, so if you see here, volumes are individual efforts. Okay, individual efforts. Okay, now we are coming to the next thing, which is going to be your inspiratory capacity. Okay, Inspiratory capacity is nothing but IRV plus tidal volume. Okay, so whenever you mix your tidal volume with the inspiratory reserve volume, then you are going to get inspiratory capacity. Okay, inspiratory capacity is going to be 3600 ml. Okay, so it is 3100 plus 500, 3600 ml. Then coming to FRC. FRC is functional residual capacity. Okay, residual capacity, which is equal to ERV plus RV. Okay, ERV plus RV, which is equal to 1200 plus 1200, 2400 ml. Next is vital capacity. Okay, this vital capacity is going to tell about the function of lung, and it is also called as functional vital capacity, which is equal to IRV plus tidal volume plus ERV. Okay, we can remember this as white. Okay, vital capacity is equal to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. Okay, so this is called as FVC, or functional vital capacity. Okay, which is equal to 3100 plus 1200 plus 500. Okay, which is equal to somewhere around 4800 ml. Okay, next is TLC, total lung capacity. Total lung capacity. Total lung capacity is equal to IRV plus tidal volume plus ERV plus residual volume. Okay, which is 4800 plus 1200 equal to 6000 ml. It's equal to 6000 ml. Okay, so this is the different kinds of volumes and capacities. Volumes are individual numbers and capacities are combos. Okay, capacity or combo. Okay, so this is very important thing. Okay, very important thing. Okay, next is FVC, or forced vital capacity. FVC, or forced vital capacity. Okay, so as I told you, this is going to be forced or functional vital capacity, which is going to be indicating function of lung. Okay, function of lung, where it is the amount of air which can be forcefully exhaled from lungs after deepest breath or inhalation possible. Deepest breath possible. Okay, and if you take vital capacity is usually is done with respect to time. With respect to time. Okay, when vital capacity is done with respect to time, it is more accurate. Okay, more accurate. Okay, so we are going to call this as timed vital capacity. Timed vital capacity. Okay, so timed vital capacity is a part of your vital capacity. Okay, now if you take your airway, this is the airway. Small vessel airways are there. Alveoli is there. Okay, now you are going to, this is the person. Okay, this is the person. Now this fellow inhales, air comes inside the bronchi, okay, bronchioles and alveoli. Okay, now what happens while exhaling the air? What is going to happen? Which air is going to come out first? So if I'm going to consider this as 1, 2, 3, 4, 5. which air is going to come out first? 1 will come out first, 2 will then followed by 2, 3 will come. Okay, so they are coming through which airways? Larger airways. Whether they will have any difficulty? No. So the air coming from the larger airways can come out easily. Okay, can come out easily. There will be no difficulty. Okay, so during the end of first second, okay, around 80% of the air will come out because there is no resistance. Okay, if I'm going to take the duration of expiration as 6 seconds, 80% of the air is going to come out during the first second itself. Okay, then in the end of second, 90% of the air is going to come out, that is next to 10%. Okay, then at the end of third second, 93% of air is going to come out. Okay, at the end of sixth second, around 98% of air is going to come out. So what happened to the remaining 2% of air? It is going to be residual volume. Okay, that is going to be residual volume. Okay, residual volume. Okay, so this is very, very important. Okay, so during first second, 80% of the air is going to come out. During second, 90% of the air is going to come out. And at the end of 6 second, 98% of the air is going to come out. Okay, and remaining 2% is going to stay back in your lung. That is going to be called your residual volume. Okay, so out of the total air which you inhaled, 98% of the air is going to come out at the end of 6 seconds, and 2% of air is going to remain in your lung. That is going to be called as residual volume. Okay, so this is going to be based on timed vital capacity. So I will come to the further details later. Next is PEFR. Okay, what is PEFR? PEFR is peak expiratory flow rate. Peak expiratory flow rate. Okay, so if the same diagram is used, okay, so here you have larger airways and smaller airways. Okay, so initially the air is going to come out from the larger airways followed by smaller airways. Okay, so this peak expiratory flow rate will tell the caliber of your larger airways. Okay, and this condition where the normal PEFR is going to be 400 to 500 ml per minute. Okay, whenever the PEFR decreases, okay, then the peak expiratory flow rate is decreased. Okay, PEFR decreased means then the peak expiratory flow rate is decreased, and it is seen in patients with asthma. Okay, asthma. Okay, so it is the air which is coming out through the larger airways, and it is normally around 400 to 500 ml per minute. And whenever it is deranged, then means that the expiratory air is going to be decreased through larger airways. Okay, larger airways. Next is we have another one called as MEFR. Okay, this MEFR is maximal expiratory flow rate. Okay, so this is actually what they mean is the forced expiration flow rate between 25 to 75%. Okay, so I told you this is part 1, part 2, part 3, part 4. Okay, if I'm going to divide it into 4 parts or 5 parts, out of the 5 parts, the air coming out from the area of 25 to 75% is going to be considered as maximal expiratory flow rate, or FEF 25 to 75%. Okay, and what this indicates actually, average flow during middle part of expiration, and this is going to be a marker or indicator of small airway disease and medium-sized airway disease. Medium-sized airway disease. Marker of smaller airway disease or medium-sized airway disease. Small airway disease or medium-sized airway disease. So this is going to be a marker of medium-sized airway disease or smaller airway disease. Okay, and this is called as MEFR or maximal expiratory flow rate, which is going to be corresponding the middle part of your expiration. Okay, next is we have another one important ratio which we are going to use in several areas called as FE1 FEC ratio. Okay, this FE1 FEC ratio is also called as Tiffany-Pinelli index. Okay, Tiffany-Pinelli index. Tiffany-Pinelli index. What is the Tiffany-Pinelli index meaning? Okay, so Tiffany-Pinelli index means, okay, this is actually proportion of patients' vital capacity that patient can expire at first second. Okay, so out of the total vital capacity, the proportion that the patient can expire at the first second is called as Tiffany-Pinelli index. Okay, so out of the total vital capacity, how much air the patient is going to expel at the end of first second is called as Tiffany-Pinelli index or FE1 FEC ratio. Okay, so this is the amount of total air. In that, how much air the patient is going to expire at the first second, that is called as Tiffany-Pinelli index, proportion of patient's vital capacity that patient can expire at the end of first second. Okay, so this is going to be your Tiffany-Pinelli index, where we are going to calculate FE1 by FEC, and this is very important. Okay, very important. So what are the normal values of FE1 and FEC? Okay, if you take FE1, the normal FE1 is going to be 80 to 120%. Okay, predicted value means the expected value, okay, or the normal value is going to be 80 to 120%. Then next is FEC. Okay, FEC, the normal value is again going to be 180 to 120%. Then next is TLC, total lung capacity. The normal value is 80 to 120%. Then next is FRC. FRC, the normal value is around 80 to 120%. For residual volume, the normal value is 80 to 120%. And the last one, which we'll discuss later, DLCO, the normal value is 60 to 120%. Okay, why all these things are given in percentage? Okay, so here if you have 3 patients coming to you, one patient is from West Indies, okay, another patient is from Japan, okay, another one male from Russia. Okay, so 3 patients are there coming to you. Okay, whether all their 3 lungs will be same, whether all their 3 lungs will be same, whether lung volume or size will be same? No. Okay, so it varies from area to area. Okay, age it varies, sex it varies, and ethnicity it varies. Okay, so based on the age and sex and ethnicity to that particular area, you have a predicted value. Okay, that is going to be in percentage. Okay, so only all the volumes are in percentage and not definitive numbers. Okay, they are not definitive numbers. Okay, so these measured values in PFT are going to be in percentage and they are not definitive numbers. Okay, so this is based on the sex, age, and ethnicity of the patient. It varies from area to area. You cannot compare a lung of an Indian with a lung of a Japanese or a Russian. Okay, so it makes difference. Okay, so this is very, very important because it is based on percentage. Okay. Next is minute or minute volume. Okay, minute volume. Okay, minute volume is total volume inspired or expired in a minute. Total volume inspired or expired in a minute is called as minute volume. Okay, minute volume is every time you inspire and expire, that is going to be tidal volume, and how many times you breathe in and breathe out is going to be respiratory rate, and minute volume is equal to tidal volume into respiratory rate. Okay, tidal volume into respiratory rate. Tidal volume into respiratory rate. Okay, tidal volume into respiratory rate. Okay, so this is going to be called as minute volume. Okay, minute volume. Now, you know, every time you are breathing in and breathing out. Okay, breathing in and breathing out. Okay, breathing in and breathing out. Okay, now whenever you breathe in and breathe out, air goes and comes outside. Okay, comes outside, and this is changed or altered whenever there is a airway disease. Okay, whenever there is a airway disease. Now, see this thing and tell me your observation. What is your observation? So here there is a airway, and this airway is very close to the alveoli. Okay, so it should be some kind of medium-sized airways. Okay, and in this medium-sized airways, you can see there is a layer of secretions. Okay, there is a layer of secretions. Okay, now what happens? Your air goes inside and comes outside. When it goes inside, how it goes? Number is more. Okay, number is more and goes very fastly. But when it comes outside, see here, number is decreased and it is very slow. Okay, that is what happens in obstructive lung disease. You can see here now again. What it means actually, expiration time is slowed or prolonged. Okay, slowed or prolonged. Okay, why this happens is, now whenever you are breathing in and breathing out, okay, some amount of air is going to stay back in your lung because of the resistance in the airway. Okay, resistance in the airway. Now what happens? Now you are breathing in and breathing out. Okay, that is an obstruction. Okay, and what happens? The information goes to the brain. Okay, and the brain tells that don't retain CO2, try to expel it out. Okay, when it tries to expel it out, what is going to happen to the expiration time? Expiration time will be prolonged. Okay, and why this expiration time is prolonged? The information goes to the brain because the air has not come out properly through the airway. Okay, so first second, the amount of air which has to come out has not come out. Okay, so what will happen? The information will go to the brain and the brain will try to push all the air outside. Okay, but this pushing of air outside, the pressure will be given both at the alveolar level and the airway level. So the airway also tries to collapse. Alveoli also tries to collapse. At one point, the airway wins over the alveoli. Okay, and actually that is in physiology called as closing volume. Okay, the point at which the airway collapses before the alveoli is called as closing volume. Okay, now what happened here? The first second, the amount of air which has to come out of the alveoli has decreased. And what happened? The information goes to the brain and the brain is trying to prolong the expiration time so that the air is expelled out for a longer duration. Okay, so what is happening here? The expiration time is prolonged, FE1 is decreased, and what happened to the FEC? FEC is almost trying to reach the normal value. When you take a ratio FE1 by FEC here, FE1 is decreased much and FEC is almost normal. Decrease by almost normal is equal to decrease. Okay, that is what happens in obstructive lung disease. Okay, that is what happens in obstructive lung disease. Okay, now here, whenever there is an obstructive lung disease, what is going to happen here? FE1 is decreased and FEC is almost trying to reach normal, or it might be slightly decreased. Okay, whenever you take a ratio FE1 by FEC, what is going to happen? It is going to be decreased. So this is the characteristic of obstructive lung disease. Obstructive lung disease. Obstructive lung disease. Okay, so the same thing which I was telling here, if you see in this picture also, I will show the thing. If you see here, what happens here? The airway lumen is normal. What happened here? There is an airway narrowing. Okay, so inspiration, there is no problem. Air is going inside because your airway is expanding. But expiration during first second, because of obstruction in the medium-sized airways, air is not able to come out. So what happened to the FE1? FE1 is decreased. But the information goes to the brain and brain is trying to push the air outside. So what happened? Expiration time is prolonged and FEC is almost trying to reach normal. Okay, when FEC is trying to reach almost normal, it will be slightly reduced. So when you take a ratio between FE1 by FEC, decrease divided by decrease, so the ratio is going to be decreased. Okay, so that is what happens in obstructive lung disease. Okay, obstructive lung disease. Okay, so whenever there is an airway block, what is going to happen? The amount of air getting expired out during the first second is decreased, so that the expiration time is prolonged and our lung will try to push the air outside. Okay, this is what happens in obstructive lung disease. Okay, so seeing here, so here this is a normal alveoli, there is an obstruction. So what is going to happen? The pressure is given on either side. At the same time, the pressure is also given over the alveoli. But what happens? Your alveoli is not able to push all the air outside. So every time what happens? Air is getting retained in your lung. And what will happen to the alveoli as time progresses? It will become ballooned out because of the increase in the residual volume. So in obstructive lung disease, what happens to the residual volume? Increases. Okay, residual volume increases. Okay, so just understand. Okay, so this is, don't write, just understand. We will write it again. Okay, so this is what happens in a case of obstructive lung disease. Okay, so so this is a normal lung. Okay, normal lung. What happens here? Every time you inspire and expire without your knowledge, what is that called as? Tidal volume. On top of tidal volume, you take a deep inspiration. Okay, what is that called as? Inspiratory reserve volume. Okay, and after inspiration, some amount of air comes outside and some amount of air retained in your lung. That is called as expiratory reserve volume and residual volume. Okay, now in your patient, you have a obstruction in the airway, and because of that, what is going to happen? The tidal volume is decreased. Inspiratory reserve volume is also slightly decreased. What happened to the expiratory reserve volume? Decreased. What happened? What is increased? Residual volume. Okay, residual volume. Okay, residual volume is increased. Okay, this is going to be a feature in obstructive lung disease. Obstructive lung disease. Coming to the next lung disease, which is going to be restrictive lung disease. Restrictive lung disease. Okay, restrictive lung disease. Okay, now this is, imagine this as a lung. Okay, now whenever you get the lung itself very small. Okay, lung itself very small. When the lung is very small, the amount of air going inside and coming out will be decreased. Okay, but there is no obstruction in the airway here. So whether there will be any difficulty in air coming out during the first second? No. So that is going to come out normally. Whenever you take a ratio between FE1 and FEC, what will happen here? Increases. In which lung disease you are going to get this? In restrictive lung disease. You are going to get this in restrictive lung disease. So Tiffany-Pinelli index or FE1 FEC ratio is increased in restrictive lung disease. It is decreased in obstructive lung disease. Okay, obstructive lung disease. Okay, so this is very, very, very important. Okay, very, very important. Now, here your lung is, how is your lung compared to the normal lung? Small, right? This lung is small. If this lung is small, what will happen to the tidal volume? That will also small. What will happen to the inspiratory reserve volume? That is also small. What will happen to the expiratory reserve volume? That is also small. What will happen to the residual volume? That is also small. So these are the features of restrictive lung disease. When the lung is small, all the volumes of the lung will be small. Okay, that is the feature of restrictive lung disease. That is the feature of restrictive lung disease. Okay, understood? So this is seen in restrictive lung disease. Restrictive lung disease. Okay, this is the feature seen in restrictive lung disease. This is the feature seen in restrictive disease. Okay, restrictive lung disease. Okay, this is the feature seen in restrictive lung disease. Okay, so this is very, very important. So what are the causes of obstructive lung disease and restrictive lung disease? Okay, causes of obstructive lung disease and restrictive lung disease. Coming to causes, you have two types of restrictive lung disease: obstructive lung disease and restrictive lung disease. If you take the causes of obstructive lung disease, it is going to be A, B, and C. Okay, A, B, and C. Okay, what is the three obstructive lung disease? Asthma. Okay, B for bronchiolitis, bronchitis. Okay, and C for COPD, in that emphysema. Another C is cystic fibrosis. So these are the three causes of obstructive lung disease. So any obstructive lung disease, it should come under A, B, C. A for asthma, B for bronchiolitis, B for bronchitis, C for COPD, and C for cystic fibrosis. Okay, cystic fibrosis. Okay, so these are the three obstructive lung disease. Coming to restrictive lung disease. Okay, restrictive lung disease. Imagine this is a lung of a patient. Okay, now in this lung of the patient, okay, what happened is, I am going to cement the lung like this. Okay, I am going to cement the lung like this. When I cement the lung like this, whether my lung can expand? No, it is a kind of restriction. Okay, now this lung derives nerve supply like this. Okay, the nerve supply only makes my lung to expand. Okay, now if I cut this nerve supply, what will happen? My lung cannot expand. Okay, so two ways I can restrict my lung: from outside the lung and from within the lung. Okay, so we have two types of restrictive lung disease. One is going to be intrinsic restrictive lung disease. Another one is called extrinsic restrictive lung disease. Okay, so within the lung you can restrict, or outside the lung you can restrict. Okay, within the lung, how you can restrict? You can use some kind of cementing material or fibrosing material. Okay, the first one is going to be interstitial lung disease. Okay, when interstitium is fibrous, my alveoli cannot expand. Second is sarcoidosis. Sarcoidosis is a kind of interstitial lung disease. Then next is pneumoconiosis. Pneumoconiosis. Pneumoconiosis is again a restrictive lung disease. Then next is you give a drug and the drug causes fibrosis, amiodarone. Okay, or patient undergoes radiation. Radiation causes fibrosis of the lung. Okay, so all these causes are intrinsic restrictive lung disease. Okay, intrinsic restrictive lung disease. Okay. Okay, so it is going to be intrinsic restrictive lung disease. Okay, extrinsic restrictive lung disease. Okay, extrinsic restrictive lung disease, how it can restrict? It is because of a injury to the spinal cord. Okay, cervical cord injury. Cervical cord injury. Okay, or it can be a nerve problem, Guillain-Barré syndrome, motor neuron disease, or it can be a muscle problem, myasthenia gravis, or it can be a spinal cord problem in the form of kyphoscoliosis, or your vertebral bones are fused. When it is fused, whether it can expand? No. Ankylosing spondylitis. Obesity. In obesity, what is going to happen? The diaphragm will be pushed up. When diaphragm is pushed up, what will happen? There will be no space for your lung to expand. So there is going to be extrinsic restrictive lung disease. So if you take your lung diseases, we are going to have two types of lung diseases, obstructive lung disease and restrictive lung disease. In restrictive lung disease, we have intrinsic and extrinsic restrictive lung disease. Okay, so the features will be common for both the conditions except for one or two exceptions. Okay, except for one or two exceptions, the feature will be common for both the intrinsic and extrinsic except for few exceptions. Okay, so how to differentiate this obstructive lung disease and restrictive lung disease? To differentiate, what we are going to do is we are going to use an investigation called spirometry. Spirometry. Okay, spirometry. So spirometry is an investigation which is done like this. Okay, so what you are doing, what the doctor is going to do, the doctor is going to give a device or instrument to the patient, and the patient is going to inspire and expire, and it is going to be recorded in a graph. Okay, graph. Okay, what are the things you have to do prior to spirometry? Prior to spirometry. Okay, the patient should stop alcohol intake 4 hours before the procedure. 4 hours before the procedure. Okay, next is he should stop smoking. Stop smoking 1 hour before procedure. Okay, he should avoid large meals. Okay, 2 hours before the procedure. Okay, and he should avoid exercise or physical activity half an hour before the procedure. Okay, so these are few precautionary measures to be taken. Okay, so these precautionary measures are important before you do spirometry. And what are the contraindication for spirometry? So what contraindications are there before going for spirometry? Okay, whenever a patient has history of MI in last 1 month, then it is contraindicated, because whenever you have MI and if you forcefully blow, what will happen? Again, it is going to increase the intrathoracic pressure and work of your heart is going to be increased. So that has to be taken care. Okay, and acute chest infection, you cannot do spirometry. Okay, in aortic aneurysm, it is contraindicated. Aortic aneurysm, it is contraindicated. In acute chest and abdomen pain, it is contraindicated. It is contraindicated in dementia patients. Dementia patients. Okay. Then next is, it is contraindicated in stress incontinence patient. Stress incontinence patient. Okay. When patient forcefully blows through the spirometer, the urine will come out in the other side. So it is contraindicated in patients with stress incontinence. Okay. So these are few precautionary measures and few contraindications which you have to take care before doing spirometry. Okay. Whenever you do spirometry, okay, the spirometry is to be blown not through the nose but through the mouth. Okay. And when you do this, you're going to get a graph. Okay. What you observe in this graph? What you observe in this graph? Any observations you can make in this graph? The inspiration is seen in the lower part of the graph. Expiration, if you see the expiration, the air comes in the initial blue part fast, but the later blue part, it is very slow. Why? Because the air is coming out through medium and smaller sized airways. So in medium and small sized airways, how will be the resistance? Resistance will be more. So airflow will be less. Okay. And what is this one called as? This is called as peak expiratory flow rate. Okay. So it is a junction between the larger airways and smaller airways. Okay. That is called as peak expiratory flow rate. Okay. Peak expiratory flow rate. And always, if you compare this graph will be like an ice cream which is inverted. Okay. Inverted ice cream. Okay. Inverted ice cream. Here we have two types of graphs. Okay. Two types of graphs. The first one is called as post expiratory flow volume curve. Post expiratory flow volume curve. Okay. So here the x-axis is going to be in time. Okay. And the y-axis is going to be in volume. Okay. In volume. Okay. Now imagine a person is coming to you. He is a not a known case of any smoking or any other comorbidities is there. And this patient, you are going to plan for spirometry as a process for his job. Okay. He takes deep inspiration followed by deep expiration. Okay. You are going to get a graph like this. Okay. If I'm going to plot this graph for first second, it is like this, and this point coincides with 5. Okay. Now this patient, scenario number 1. Okay. Scenario number 1. Okay. Where FE1 is going to be 4, FEC is going to be 5. 4 by 5 is 80%. 4 by 5 into 100. Okay. 20. 44 into 20 is going to be 80. So this person FE1 by FEC is going to be 80%. Okay, 80%. So whenever your FE1 by FEC is more than 80%, then it is considered as normal. Okay, normal. Whereas if your FE1 by FEC is less than 70%, it is considered as obstructive lung disease. Now we are going to have the next patient coming to you, where the patient is going to be breathing in and breathing out. Okay, you are going to get a graph like this. Okay, now if you consider in this person, second scenario, FE1 is equal to 3, FEC is 4.5. When you take a ratio between 3 by 4.5 into 100, then you will get somewhere around 66%. Okay, so what kind of lung disease it is? It is going to be obstructive lung disease. Okay, you told the patient not to smoke, but he didn't follow your advice and he comes to you after 5 years. Okay, third scenario, where FE1 by FEC equal to 1.5 by 3.5. Okay, 1.5 by 3.5 into 100. Okay, so it will come somewhere around 40%. What kind of lung disease it is? Severe obstructive lung disease. Okay, severe obstructive lung disease. Okay, so this is seen in severe obstructive lung disease. Okay, severe obstructive lung disease. Okay, now you have 3 patients coming like this, and you have the fourth patient. Okay, fourth patient, where the patient is coming to you. Okay, where this patient is going to have a graph like this. Okay, this is the fourth graph, arrowed graph. Okay, the fourth graph, if you take FE1 by FEC, I'm going to calculate. Okay, FE1 is 3.3. Okay, and FEC is 3.5, for example. Okay, 3.5. Now FE1 by FEC, how much it will come? Around 94%. Okay, so what kind of lung disease this one is? It is normal, or it can be a restrictive lung disease also. Can be a restrictive lung disease also. Okay, it can be a restrictive lung disease because it is more than 80%. So it is going to be normal or restrictive lung disease. Okay, so this scenario is seen in case of restrictive lung disease. If you see these 3 graphs, okay, at a closer look, when it tries to reach almost it tries to reach the normal graph, okay, then it is going to be obstructive lung disease. Whenever it is far away from the normal graph, then it is going to be more of a restrictive lung disease. Okay, so seeing the graph itself, you can tell whether it is an obstructive lung disease or restrictive lung disease. When it is very near to the normal graph, then it is going to be obstructive lung disease. Whenever it is far away from your regular graph, then it is going to be restrictive lung disease. Okay, so these are the graphs you can get in post expiratory volume curve. Okay, post expiratory volume curve. Okay, so if this is the graph, okay, what is the first graph? First graph is normal. What is the second graph? What kind of lung disease? Obstructive lung disease. What is the third graph? Restrictive lung disease. Okay, so seeing the graph itself, you should be able to tell whether it is a normal graph, obstructive lung disease, restrictive lung disease. Okay, so this is very important. Okay, very important, and this is called as your post expiratory flow curve. Okay, post expiratory flow curve. Okay, very important thing. Okay, next we come to flow volume loop. Flow volume loop. Okay, flow volume loop. Okay, how this flow volume loop is very important. Okay, now imagine a person is given a spirometer. Okay, now what happens, this is, imagine this as a spirometer and there is a sensor in the spirometer. What I'm going to do is I'm going to take a deep inspiration followed by a deep expiration. Okay, whenever I take a deep inspiration, the air is moving away from the sensor. Okay, when I am blowing in, what is going to happen? The air is going to move towards the sensor. Okay, so whenever I am going to take a deep breath, what is going to happen is the air is going to come inside. Okay, then what is going to happen? I am going to blow out. When I blow out, the air is going to come out initially from the larger airways. Then what happens? It is going to come out through the smaller airways like this. Okay, and this point is called as peak expiratory flow rate. Okay, peak expiratory flow rate. Now, considering this point where I started breathing, and this point, this is the starting point, this is the end point, and this is considered as TLC. Okay, TLC. And what happened? We didn't reach the starting point, so some amount of air is not revealed. What is that air which is not revealed? Residual volume. Okay, residual volume. From residual volume, if you subtract from TLC, if you subtract residual volume, what you're going to get? It is called as FVC. Okay, so this part is called as FVC. Okay, and this part is called as RV. Okay, for just for imagination sake, I'm telling, the air is coming out through the larger airways followed by medium sized airways. So almost this point is the 80% point. But you cannot calculate the percentage here because this is a flow volume loop. Here you cannot calculate the percentage, but approximately this corresponds to 80% of the air. Okay, 80% of the air. Okay, so this is the inspiratory limb. This is the expiratory limb. Inspiratory limb and expiratory limb. Okay, now coming to the next scenario. Okay, now this is the normal graph. Normal graph. Now your patient is having mild history of smoking. Because of this, mild obstructive lung disease is there. Okay, now what happens? The patient inspires. There is no problem in inspiration. There is no problem in larger airways. But what happens? The air is not able to come out from the medium sized airways. So it is trying to reach almost to the normal graph, but it is not attaining the normal graph. Okay, so what happened here? This part has increased. What is this part is increased called as? Residual volume is increased. When residual volume is increased, which volume is decreased here? FVC is decreased. Okay, how this looks like? This looks like something has been scooped out. Okay, so something has been scooped out or removed. Okay, from the normal graph. So this is called as scooped ice cream appearance. Scooped ice cream appearance or dog leg appearance or dog leg appearance. Okay, dog-like appearance. Now this person, you told him to stop smoking, but he never listened to you. He keeps on smoking. Okay, after 5 years, he is coming back to you. Okay, after 5 years, he is coming back to you. His inspiration, no problem. Expiration, there is problem, and it has become like this. Okay, what happened to the residual volume? Increased. What happened to the FVC? Decreased. Okay, now in this patient, he developed severe obstructive lung disease. Okay, as the severity increases, where is the curve shifting? When you are writing, whether the curve is shifting towards the right side or left side? Left side. So in obstructive lung disease, the shift is towards left side. So in obstructive lung disease, the shift is towards left side. In obstructive lung disease, the shift is towards left side. Okay, shift is towards left side. Now we are going to see the third patient. This is a normal lung. Okay. Now the third person is coming to you. Okay. What is this? What is this picture? India. What is this one? Mini India or restricted India. Okay. Now you have a normal lung and your patient has a mini lung or a restricted lung. Then it is going to be called as restrictive lung disease. You can tell this in another way also. Okay. This patient has a small lung. Okay. Small lung means what? How will be the inspiration? Small. He inspires. Okay. How will be the expiration? Small. Okay. Where is the curve getting shifted? Right side. So in restrictive lung disease, the shift is towards right. Understood? Understood? See, in restrictive lung disease, okay. So I'm using just for explanation, I'm using in Tamil. Okay. So அவர் மூச்சு இழுக்கிறாரு. மூச்சு இழுத்தோன்னே என்ன ஆகும்? லங் ஃபில்லப் ஆயிடுது. கொஞ்ச நேரத்திலே கர்வ் முடிஞ்சிடுமா? முடிஞ்சோடனே எக்ஸ்பயர் பண்றாரு. எங்க மூச்சு இழுத்து முடிச்சாரோ அங்கே எக்ஸ்பிரேஷன் ஸ்டார்ட் ஆயிடும். அப்ப என்ன ஆகும்? கர்வ் வந்து will be shifted towards the right side. Okay, because the inspiration volume is small, from there itself expiration will start. So the expiration volume is also going to be small. Okay, so for understanding, it is going to be a miniature form, but in reality it is going to be shift towards the right side. Okay, so that is called as restrictive lung disease. Okay, restrictive lung disease. Okay, very, very important thing. Very, very important thing. Now, if you see here, what is this first graph? Normal. What is the second graph? What is the third graph? Restrictive lung disease. Okay. What is the first graph? Second graph? Third graph? Fourth graph? Restrictive lung disease. Okay. எனக்கு எதுவுமே ஞாபகம் இல்லை, எல்லாமே குழப்பது, புரியவே இல்லை. Okay. So one just simple example. You have a bean bag in your home. Okay. When you use the bean bag for some duration, when you use it for a longer duration, when you buy the bean bag itself like that, then it is restrictive lung disease. Okay, so this is a bean bag which looks like a inspiratory part, expiratory part. When you use it to some time, what is happening? Shift towards the left. When you use it for a longer duration, more shift towards the left. When the bean bag size itself small, then it is going to be restrictive lung disease. Okay, so these are the volume curves you are going to get in cases of airway diseases. Okay, next is we are going to come to another one, lung disease. which is going to be obstruction in the airway. Okay, so what is this one? A coin. Okay, this coin is within the thorax. So whether it is a intrathoracic obstruction or extrathoracic obstruction, it is within the thorax. Okay, so it is going to be an intrathoracic obstruction. Okay, now imagine, imagine this as an airway. Okay, here there is a coin. Okay, when I inspire, what will happen? The lumen will increase in size, so air can go inside. Okay, there will be no difficulty in air going inside. When I expire, what is going to happen? Airway collapses. So what will happen? Obstruction will increase, so air cannot go outside. Okay, so whenever I'm going to plot a graph for this one, okay, so this is a normal graph. In this person, there is no problem in inspiration, so inspiration will be normal, but during expiration you will get a curve like this. Okay, so whenever you have a intrathoracic obstruction, the limb which is going to be affected is going to be expiratory limb. Okay, and what kind of obstruction it is? A fixed one or a variable one? Coin can move, right? So it is variable intrathoracic obstruction, or VITO, variable intrathoracic obstruction. Okay, VITO or variable intrathoracic obstruction. Variable intrathoracic obstruction. Okay, variable intrathoracic obstruction. Variable intrathoracic obstruction. Variable intrathoracic obstruction. So in intrathoracic obstruction, which limb will be affected? Expiratory limb. Okay, in intrathoracic obstruction, expiratory limb will be affected. Okay, so this is very, very important. Okay, next is another patient is coming to you. Okay, this patient has a large tonsils. Okay, large tonsils, or this patient is a psychiatric patient. The patient was told to take tablet, and he took the tablet in this form itself. Okay, now this tablet obstructed here. Okay, when the tablet is obstructed here, whether it is intrathoracic obstruction or extrathoracic obstruction? Extrathoracic obstruction. Now I take a deep inspiration. What will happen to this tablet or whatever it is? What it will happen? It will go inside and obstruct the airway. Okay, when he blows out air, what is going to happen? Because of the force of the air, the foreign body is going to come out, air will come out. That is what happens, right, in extrathoracic. Okay, so imagine it's like this. Okay, when I inspire, what will happen? The ball will go inside and obstruct. When I expire, what is going to happen? The air will come and push the ball, and air can escape outside. Okay, so here inspiration is affected or expiration is affected? Inspiration அப்ப ball உள்ளார போயிடுது. Expiration அப்ப because of the force of the air, the ball goes outside. So which part will be affected? Here it is going to be inspiration which is affected. Okay, inspire பண்ணும்போது ball வந்து because of the force of the air, நீங்க இங்க ball இருக்கு, இப்படி இருக்கு, inspire பண்ணும்போது என்ன ஆகும்? அந்த air வந்து ball push பண்ணும், so ball will go and obstruct. When I expire out, what is going to happen? The air is going to push the ball, the ball will move outside. Okay, move outside. Okay, so here what is going to happen? The inspiratory limb is going to be affected, the expiration part is going to be normal. Okay, so here a kind of obstruction here is going to be extrathoracic obstruction, where the inspiratory limb is going to be affected, and this is called as variable extrathoracic obstruction, VITO. Variable extrathoracic obstruction. Variable extrathoracic obstruction. Now comes the third patient. Now comes the third patient. In the third patient is a known case of carcinoma who underwent surgery, and post surgery he was on radiotherapy. Okay, radiotherapy. After radiotherapy, what happened is he developed an obstruction, and this obstruction is within the thorax or outside the thorax? Within the thorax. Whether it is a fixed obstruction or a variable obstruction? Fixed obstruction. So this fellow developed fixed intrathoracic obstruction. Okay, whenever he develops fixed intrathoracic obstruction in this kind of airway, there will be difficulty in air going inside and coming outside. So which part will be affected? Both inspiratory part and expiratory part. Because of that, you are going to get a graph which is looks like a box. Okay, and because of this, he gets box shaped curve, which is seen in fixed intrathoracic obstruction. Okay, so these are the graphs what you get in spirometry in patients with respiratory diseases. Okay, so this is very important to know. Okay, so if you know the graph, you will be able to identify the different conditions. Okay, different conditions. Okay, now coming to this one, what is the first graph? Which part is affected? Inspiratory part or expiratory part? Expiratory part is affected. Expiratory part is affected means variable intrathoracic obstruction. Variable intrathoracic obstruction. This one, second one. Inspiratory part is affected. So where should be the pathology? Expiratory. Veto. What is this one? Both. So it is veto. What is this one? This is actually looks like your bean bag. Okay, so what kind of thing it is? Obstructive lung disease. If this is like this, then it is going to be normal, but if it is going to be like this, then it is going to be obstructive lung diseases. Okay, so it is like scooped out appearance, right? So it is going to be a case of obstructive lung disease. Okay, obstructive lung disease. Okay, so this is the graph what you get in different kind of lung diseases. Okay, different kind of lung diseases. Okay, so here very important thing is, whenever you have any case which is given in your exam, okay, as obstructive lung disease or restrictive lung disease, the first step is you see for FE1 FEC ratio. Okay, when FE1 FEC ratio is low, okay, that is less than 0.7, then it is going to be a case of obstructive lung disease. Obstructive lung disease. Okay, whenever FE1 by FEC ratio is normal or increased, okay, you have two kinds of pathologies. Okay, one is going to be normal, another one is going to be restrictive lung disease. Okay, in restrictive lung disease, I told you that it is going to be FEC, which is going to be less than 80%. Okay, FEC will be decreased. Okay, FEC will be decreased. Then you have to see whether it is a intrinsic restrictive lung disease or extrinsic restrictive lung disease. Okay, so here we have to consider residual volume. Okay, residual volume is normal in extrinsic restrictive lung disease because elastic recoil of lung is normal. Okay, because elastic recoil of the lung is normal, and this elastic recoil of the lung only determines RV. Okay, so only elastic recoil of the lung defines your residual volume, right? Whenever the elastic recoil is normal, then residual volume is going to be normal. Okay, so in intrinsic restrictive lung disease, what is going to happen is there is going to be decrease in the RV. Okay, decrease in the RV, and whenever you take RV by TLC ratio, TLC is decreased, RV is decreased. So overall, if you take a gradient, the gradient is going to be normal. To decreased value, it is going to be normal. Okay. Whereas in extrinsic restrictive lung disease, RV is going to be normal, TLC is going to be decreased. Whenever you take a gradient, then it is going to be increased. Okay. So this will define what kind of lung disease it is, whether it is an intrinsic restrictive lung disease or extrinsic restrictive lung disease. One more thing, one more parameter is, which we'll discuss later, DLCO. Okay, DLCO is decreased in intrinsic restrictive lung disease. DLCO is normal in extrinsic restrictive lung disease. Okay, this we will discuss why it is so later. But now you remember, you have to calculate RV by TLC. Okay, RV by TLC is normal in intrinsic and increase in extrinsic restrictive lung disease. Okay, this is very, very important. Okay, so what is RV? RV is residual volume. It depends upon the elastic recoil of the lung, and it is normal in extrinsic, but it is decreased in intrinsic restrictive lung disease. Okay, this is very, very important. Okay, very, very important. Okay, so this is very, very important to differentiate a intrinsic restrictive lung disease from extrinsic restrictive lung disease. And this graph or flowchart is very, very important to make which kind of lung disease it is. Okay, which kind of lung disease it is. Okay, so with this we will finish spirometry part. Okay, we will just discuss few questions. Okay. So this is a 20-year-old female with past medical history of significant tobacco use. Okay, female smoker, ASD and intermittent asthma, clinically diagnosed when she was a child, now presents with shortness of breath. Okay, until recently she felt that her asthma symptoms were under control and not used her inhaler for months. She notes an insidious onset of dyspnea on exertion over the past 1-2 years. She mainly has noted difficulty in performing a daily aerobic exercise due to dyspnea. She tried her salbutamol inhaler with only mild relief of her symptoms. She feels her symptoms only occur during physical exertion and feel different than her previous asthma symptoms. So this is the scenario. The patient tells that she is a known case of asthma. she is on regular medications previously, but after that she stopped medications. But now recently she developed breathing difficulty. Okay, and she feels that this is not equal to her routine asthma symptoms. And usually, whenever she gets asthma symptoms, she take medications, it gets relieved, but this is not getting relieved. Okay, and this is a spirometry report. This is the option. What should be the answer? What should be the answer? Variable? 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 Variable extrathoracic obstruction. If you see the graph here, you can see what happened here. You can see the inspiratory limb, that green graph is away from the normal graph. Okay, so when the green graph is away from the normal graph means it is small. So what it is, what kind of obstruction it is? VETO, variable extrathoracic obstruction. Okay, variable extrathoracic obstruction. Okay, so the simply what they want to know is they want you to interpret this graph and tell the answer. Okay, it is variable extrathoracic obstruction. What should be the answer? Huh? Exercise tolerance of less than 50 meter. Okay, so recent MI is a contraindication, abdominal surgery is a contraindication, being acutely unwell is acute infection is contraindication. Patient has exercise tolerance of less than 50 meter means patient has some kind of restrictive lung disease. Okay, exercise intolerance means patient walks 50 meter, patient develops breathing difficulty. It means that it is interstitium is getting involved. Okay, so patient whenever walks, the demand is more, but the supply is less. Okay, so it means that it is a case of restrictive lung disease. So it is not a contraindication. It is away from the main graph, so it should be restrictive lung disease. Chronic. Okay, so the patient came to clinic, 46-year-old female, smoker. She presents with exertional dyspnea, which has been present on and off since she was a teenager. Her spirometry pre and post bronchodilator reveals the following. Okay, so if you take the first option, asthma. Okay, so asthma is a condition where there is a smooth muscle hypertrophy or hyperresponsiveness, which is reversible. Okay, so when you give a bronchodilator, it should reverse back. So, but here it has not reversed back. 85%, 87%. Okay, so first option is ruled out. Coming to D, bronchiectasis. Other than dyspnea, there is no other symptom is given here. So bronchiectasis also ruled out. Next is chronic bronchitis and emphysema. Okay. So here, if you see here, since the age of teenager, she is having this complaints. Okay. Chronic bronchitis usually occurs as the number of smoking years increases. Okay. But here, it's being a teenager, she develops the symptoms means she is having some kind of emphysema which occurs due to genetic mutation. Okay. Which is due to alpha-1 antitrypsin deficiency. And this indicates that this is a case of emphysema due to genetic involvement, which we will see later. Okay. So the answer is going to be here. Most probably emphysema is a better option than all the other options here. Okay. If the same question, if they have given FE1 by FEC ratio post bronchodilator is going to be increased. Asthma. Okay. Asthma. Okay. And here again, one more justification I can give for asthma here. One more justification is FE1. Okay. FE1 alone has improved drastically here. Okay. It is more than around 12%, more than 12%. So again, asthma can be used as an option here. Since smoker is the option, I am going for emphysema. Okay. If smoker is not given here, then it is going to be more towards asthma. Okay. Smoker is not given, then I will go more towards asthma. Since smoker and young patient developing breathing difficulty both goes hand in hand with emphysema, that even only one emphysema, that is going to be called as pan-acinar emphysema. Okay. Otherwise, the better option is to go for asthma. Okay. Better option is to go for asthma. Okay. It is a obstructive lung disease. So what should be the answer? Here it is asthma. Okay. Because FE1 by FEC ratio is less than 80%. So hypersensitive pneumonitis is ruled out. Rheumatoid lung disease is ruled out. We have only two options here. Okay. And this history is a very short history, 3 months history. So here the better option is going to be asthma. Okay. Asthma. What is minute volume? Tidal volume into respiratory rate. So what they want here, tidal volume. So it is going to be 7.35 liters divided by 18. Okay. It should be 408 ml. Okay. It should be 408 ml. Okay. So 7350 by 18. Okay. It will come around, okay, 408 ml. Okay. It should be B, TLC minus VC. VC minus ERV. Okay, VC I told you white. Okay, ITE. In ITE, if you cut E, it is IT. IT is IC. What they want? Residual volume. FRC is equal to ERV plus RV. So we require RV. So FRC minus ERV is equal to RV. 3300 minus 1500, 1800 ml. Okay, 1800 ml. They want FRC. What is FRC? ERV plus RV. 1100 plus 1150, 2250 ml. FE1 by FEC should be less than 80% predicted. TFR should be decreased in obstructive air disease. TLC should be increased in obstructive airway disease. A 15% improvement post bronchodilator challenge tells that it is a case of ASPA. That is, it is a reversible condition. Okay. Compared to predicted normal values, a patient has a normal FE1 by FEC ratio, normal FEF 25 to 75%, but a markedly reduced FEC. Which of the following is the most likely problem? It is a restrictive disorder because FE1 by FEC ratio is normal, but FEC is reduced. So it should be a restrictive pathology. Easy one. Chronic bronchitis, FE1 by FEC is decreased. Okay, it should be obstructive lung disease. So A, B, C. Okay, out of that only one thing we have here, chronic bronchitis. Even if you don't know, silicosis, again pneumoconiosis. Kyphoscoliosis, again restriction. Pneumothorax, again restriction to the lung expansion. TLC is white plus ERV, right? White plus ERV. Okay. Now what we have here? FRC. So TLC minus FRC is equal to IC, right? So what you are going to get here? 3200 ml. Okay, 3200 ml. Answer is, so TLC is equal to tidal volume plus IRV plus ERV plus RV, correct? TLC is equal to white plus R. So whiter TLC. TLC is equal to inspiratory capacity plus FRC because it is TV plus IRV. FRC is ERV plus RV. TLC is equal to VT. In VT itself already we have ERV. Okay. So this option is wrong. Okay. Answer is A. Okay. So even the simple numbers can be questions in your exam. Simple volume curve, volumes and capacities can be question in your exam. Okay. So this is about your spirometry. After spirometry, we are going to come to next one important topic, which is going to be diffusion capacity. Okay. So diffusion capacity is also called as DLCO. Okay. So what is DLCO? Okay. DLCO is diffusion lung capacity for carbon monoxide. for carbon monoxide. Okay, diffusion of lung for carbon monoxide. Okay, why this DLCO is important? Okay, if you take here, normally what is going to happen? There is going to be gas exchange. These are the alveoli. Okay, this is an alveoli where you have blood vessels, capillaries. Okay, now what is going to happen? This is the alveolar membrane. This is the capillary endothelium. The air is going to enter into the alveoli and then it crosses the alveolar epithelium, interstitium and enter into the blood vessel. Right? In turn, what is going to happen? You are going to have carbon dioxide which is going to cross and enter into the alveoli. Okay, so any gaseous exchange should happen means it has to cross the alveolar epithelium, interstitium and vascular endothelium. Okay, so for gas exchange it has to cross through three important areas, which is going to be your alveolar epithelium, interstitium capillary endothelium. Capillary endothelium. Okay, here in DLCO I am going to use an important gas which is going to be carbon monoxide. Carbon monoxide. Okay, why I am using carbon monoxide? Carbon monoxide has 210 times more affinity for hemoglobin. Okay, you have two types of gases. One is called diffusion limited gases and another one is called perfusion limited gases. And carbon monoxide is a diffusion limited gas. Diffusion limited gas. What is this diffusion limited gas is? Throughout the respiration cycle, the concentration of carbon monoxide in alveoli is always more than that of capillary. Okay, but this is a diffusion limited gas. Okay, diffusion limited gas. But what happens? Our oxygen and carbon dioxide, okay, they are going to be called as perfusion limited gases. Okay, perfusion limited gases means it is depends upon the perfusion. Okay, why it depends on perfusion means there will be always a saturation kinetics. Okay, saturation kinetics, that is, even if you give 100% oxygen, okay, for 2 hours, okay, or 3 hours, once a saturation is reached in the blood, okay, that is, it will take up only the required amount of oxygen, not more than that. Okay, so oxygen on the கிட்டத்தட்ட it is like போதுமென்ற மனமே பொன் செய்ய விரும்பு, it will tell enough. Okay, but what is happening in carbon monoxide? நீங்க எவ்வளவு கொடுத்தாலும் carbon monoxide உங்க RBC வாங்கிக்கிட்டே இருக்கும். Okay, it will receive how much ever amount of carbon monoxide you are giving. Okay, so carbon monoxide is a diffusion limited gas, whereas your oxygen and CO2 is going to be perfusion limited gas. Okay, perfusion limited gas. Okay, so this is very, very important and this is a very, very potential MCQ. Carbon monoxide is used because it is a diffusion limited gas. Okay, diffusion limited gas. Diffusion limited gas. Okay, so how will you calculate the oxygen content in blood. Okay, if you want to calculate the oxygen content in the blood, you have to use a formula where 1.34 into Hb into SpO2, okay, plus 0.03 into PaO2. Okay, so it is the formula where you have hemoglobin, saturation, partial pressure of oxygen, partial pressure of oxygen. Okay, so you all know that why this 1.34 is one molecule of hemoglobin will bind with 1.34 ml of oxygen. Okay, so for that only we have putting 1.34 here. Okay, so one hemoglobin molecule will bind with 1.34 ml of oxygen. Okay, so the oxygen binding capacity is equal to 20.1 ml of oxygen for per deciliter of blood. Okay, so per deciliter of blood will bind with 20 ml of oxygen. Okay, average around 20 ml of oxygen. Okay, so because this oxygen content is very important in few conditions. Okay, very important in few conditions. Okay, so why it is very important is if you take carbon monoxide poisoning, okay, there will be more amount of carbon monoxide. Okay, because of that, what is going to happen? The dissolved oxygen in the blood will decrease. Okay, so in certain conditions like cyanide poisoning, okay, cyanide poisoning, what happens? PaO2 will be normal, saturation will be normal, oxygen content in the blood will be normal, but this cyanide will cause disturbance in the ETC chain. Okay, because of the ETC chain, the patient will develop cyanosis. Okay, so it depends upon which mechanism causes what. Okay, when you go to high altitude, what is going to happen? PaO2 will decrease, SpO2 will decrease, oxygen content will decrease. Okay, so in different situations, different scenarios can arise, and they can give you a question, and they can ask you what are the conditions, what will happen, what can be the oxygen content. Okay, for example, if since this is not a discussion here, okay, which is required, it is actually physiology discussion, but anyway I will tell you. In carbon monoxide poisoning, okay, what will happen to the PaO2, SpO2, oxygen content? The PaO2 will be normal, saturation will decrease, and oxygen content will decrease. Okay, even though the partial pressure of oxygen is normal, the dissolved oxygen content in the blood will decrease. Okay, whereas if you take cyanide poisoning, in cyanide everything will be normal. In anemia, what is going to happen? Anemia, PaO2 will be normal, SpO2 will be normal, but the dissolved oxygen content in the blood will decrease. Okay, whereas in polycythemia, PaO2 is normal, SpO2 will be normal, but the dissolved oxygen content in the blood will be increased. When you go to high altitude, PaO2 will decrease, saturation will decrease, and dissolved oxygen content in the blood will decrease. Okay, so this actually in physiology it is a very important table. Okay, in different conditions, what will be the PaO2, SpO2, and oxygen content? Okay, oxygen content. Okay, so this is very important thing. Okay, so what is perfusion limited gas? What is diffusion limited gas is very important. And what kind of gas is our carbon monoxide? Diffusion limited gas. Okay, whereas oxygen and carbon dioxide are perfusion limited gas. Okay, so coming to the next scenario, what is going to happen now? You every time you breathe in oxygen and breathe out CO2. Okay, so this oxygen is going to enter into the alveolar epithelium, interstitium, and capillary endothelium. Okay, so it has to cross all these three barriers to enter into the RBC. Okay, whenever there is a problem in any of these barriers, what is going to happen is your oxygen cannot go and bind to the RBCs, and this you are going to demonstrate using carbon monoxide. Okay, carbon monoxide. If you see here, this is the alveolar membrane, interstitium, and the endothelium. Oxygen will go and bind to the RBCs. Okay, RBCs. Okay, now what happens? You use a gas which is going to be carbon monoxide, which has more affinity to your carbon monoxide, has more affinity to the RBCs. Okay, now for example, if I'm going to give you 10 ml of carbon monoxide, 10 ml of carbon monoxide. Okay, out of this 10 ml of carbon monoxide, 9 ml is going to go and bind to the RBCs, remaining 1 ml is going to come out, right? Remaining 1 ml will be expelled out. Okay, now if I am going to take the DLCO here, it is equal to 10 ml minus 1 ml. How much is the ml? 9 ml. Okay, so if I am going to convert this into percentage, DLCO is equal to 90%. Okay, whether this is a normal DLCO or abnormal DLCO, it is a normal DLCO. So here it is going to be 90%. Okay, 90%. Okay, imagine there is another condition where here there is a fibrosis. Okay, here there is a fibrosis. Okay, what happened here? Because of the fibrosis, the epithelium is intact, interstitium is affected, endothelium is normal. Okay, whether your carbon monoxide can enter into the RBC normally, it cannot cross the barrier. Okay, now if it is not able to cross the barrier, if I'm going to give 10 ml, okay, 10 ml, the carbon monoxide binds with the RBCs, and remaining carbon monoxide which is going to be expelled out is going to be 6 ml. Okay, here if I'm going to calculate DLCO, 10 minus 6 equal to 4 ml or 40%. What happened to the DLCO? Decreased. Okay, DLCO is decreased. So any condition where there is a involvement of your epithelium, interstitium, or the blood vessel endothelium, then your DLCO will be decreased. Okay, so what are the conditions where DLCO will be decreased? DLCO will be decreased. Okay, so DLCO can be decreased in a time restrictive condition. A time restrictive condition. Okay, what are the time restricted condition? Whenever your alveoli is getting filled up, for example, ARDS, what will happen? DLCO will be decreased. Then TI, TI is tension in the pulmonary vessel, pulmonary hypertension. Okay, whenever your blood vessel is blocked by embolism, pulmonary embolism. Next is whenever your alveoli is ballooned out, when your alveoli will get ballooned out, emphysema, emphysema. Okay. Next is restrictive lung disease due to interstitial lung disease. Interstitial lung disease. Interstitial lung disease is what kind of restrictive lung disease? Intrinsic or extrinsic? Intrinsic. Intrinsic. Okay. In extrinsic restrictive lung disease, whether there is any pathology involving the alveoli, interstitium, or endothelium? No. So how will be the DLCO in extrinsic restrictive lung disease? Normal. So DLCO will be normal in extrinsic restrictive lung disease. DLCO normal in extrinsic restrictive lung disease. Now, you have the next scenario where you give 10 ml. Okay, 10 ml. Now, what happened? For unknown reason, your RBCs are in the alveoli itself. Okay, your RBCs are in alveoli itself. Okay, now out of this, only 0 ml is going out. Okay, now what happened? 10 minus 0 equal to 10. If I'm going to convert into percentage, 100%. Okay, 100%. DLCO is 100%. Whether it is increased or decreased, it is increased. Okay, normal or increased. Okay, so whenever it is increased, it should be some pathology which causes increased absorption of your carbon monoxide. Okay, so what are the conditions where your DLCO will be increased? Okay, what are the conditions where DLCO will be increased? Okay, so it is going to be alveolar hemorrhage, PAH, pulmonary alveolar hemorrhage. Then more amount of RBCs in your blood vessel, when you will have polycythemia. Whenever you do exercise, what will happen? The heart is going to pump fastly, and what will happen? There will be more blood flow for oxygenation. Okay, so exercise causes increase in DLCO. Okay, exercise causes increase in DLCO due to the redistribution of blood flow. Redistribution of blood flow. Then next condition, in acute asthma. Acute asthma. In acute asthma, what is going to happen is there is going to be release of nitric oxide. Okay, what is nitric oxide will do? It will cause vasodilation. So what will happen to the blood flow? Increases. So what will happen to the DLCO? Increases. So in nitric oxide release in acute asthma, there is going to be increase in the DLCO. Okay, so these are few conditions where DLCO will be increased. Coming to congestive heart failure. Okay, whenever there is congestive heart failure, what is going to happen? The heart is going to contract very fastly as a compensation method. Okay, when the heart is contracting very fastly as a compensation method, what happens? The amount of blood entering into the lung increases. What will happen to the DLCO? Increases. So in mild or early congestive heart failure, what will happen to the DLCO? Increased. But in severe cases, what will happen? The heart contraction is going to reduce. When heart contractility reduces, what will happen to the blood flow to the lungs? Decreases. So what will happen to the DLCO? DLCO will be decreased. So in late congestive heart failure or decompensated congestive heart failure, the DLCO will decrease. Okay, so this is very important. Okay, very important. Okay, so this is the conditions which are associated with the decreased and increased DLCO. Okay, so if I'm going to summarize as a difference between obstructive lung disease and restrictive lung disease, okay, first one is FE1. Okay, what will happen to the FE1 in obstructive lung disease? FE1 will decrease. In restrictive lung disease, normal. Next is what will happen to the FEC? Normal or decreased. What will happen in restrictive lung disease? Decreased. What will happen to FE1 by FEC? Going to be reduced. What will happen here? Normal or increased. Next is what will happen to the residual volume? Increased. Here it is decreased. What will happen to the TLCO? TLC is going to be increased here, decreased here. What will happen to the DLCO? DLCO will be, in obstructive lung disease, it is going to be normal, except for one condition. Which is that condition? Emphysema. Okay. And what will happen to the DLCO in restrictive lung disease? It is normal in extrinsic restrictive lung disease. It is decreased in intrinsic restrictive lung disease. Intrinsic restrictive lung disease. Okay. So this is one important difference you should know in cases of obstructive and restrictive lung disease. Okay, obstructive and restrictive lung disease. Okay, very, very important thing. Okay, so if you take TLC, RV and FRC, what is the most common thing among the three things? Which is common for all the three things? It is going to be RV. Okay, residual volume. Residual volume is the amount of air which is retained in the lung. Okay, whether it can be measured directly by spirometry? No. So to measure RV, what we can do is you can use certain method called helium dilution method, nitrogen washout method, body plethysmography. Okay, out of this, which is the best method to measure lung volumes? Body plethysmography. Okay, body plethysmography. Okay, body plethysmography. Okay, very, very, very important one. Okay, so this is one way where you can assess the lung volumes. Okay, lung volumes. Okay, lung volumes. Okay, so here again I'm finishing with one more graph here, one more flow chart, which is again going to be handy for your diagnosis. Okay, so why this graph is important is last year we had a question from this topic. So this graph is very, very important to solve that question. Okay, now first step is again, as I told you, FE1 by FEC. Okay, FE1 by FEC is reduced, normal or increased. Okay, normal or increased. Whenever it is reduced, okay, then it is going to be obstructive lung disease. Obstructive lung disease. Okay, this obstructive lung disease occurs because of two reasons. Okay, one is hyperinflation of the lung, another one is air trapping. Okay, hyperinflation and air trapping. Okay, in hyperinflation conditions, what is going to happen is TLC is going to be increased. Okay, TLC is going to be increased and FEC is going to be normal. These are variants of what generally we discussed. Okay, next is air trapping. In air trapping, what is going to happen is TLCO is going to be normal, FEC is going to be decreased. Okay, air trapping, FEC is going to be decreased. What they mean is hyperinflation is your alveoli becoming bigger. Air trapping is your airway is becoming narrower. That is the meaning. Okay. So whenever you have these two things, these two variants, then you have to think about either it should be hyperinflation or air trapping. Okay, air trapping. Next is coming to FE1 by FEC is increased. Okay, FE1 by FEC is increased or normal. Okay, now here we have two scenarios. One scenario is FEC is normal and DLCO is decreased. Okay, what is this condition? Where should be the pathology? FEC is normal. FEC is normal means what is happening? Airway is normal, but DLCO is decreased and it is a restrictive lung disease. It should be vascular pathology, right? Vascular pathology. It should be either pulmonary embolism or pulmonary hypertension. Okay, pulmonary embolism or pulmonary hypertension. Okay, now your FEC is decreased. Okay, so it is a case of restrictive lung disease. Restrictive lung disease. Okay, just here one thing I want to tell, just you have to memorize this, no other go. Whether it is intra parenchymal or extra parenchymal. These kind of questions are for INISET, okay, INISET reason, okay, intraparenchymal or extra parenchymal, okay. In intraparenchymal, what is going to happen? There is going to be decrease in the DLCO. In extra parenchymal, there is going to be normal DLCO. The second is a terminology which is commonly used in USMLE questions, okay, called as KCO, okay. KCO is coefficient of gas transfer, okay, coefficient of gas transfer, coefficient of gas transfer, okay. And this KCO is normal in intraparenchymal. This KCO is increased in extraparenchymal. This you have to memorize, no other go, okay. KCO is coefficient of gas transfer, okay. So this difference will tell you whether it is a intraparenchymal disease or extraparenchymal disease. If you take NEET level question, they will not cross DLCO. If you go to INISET, they will ask about KCO, okay. So that is the difference, okay. So this is one important thing which you have to know, okay. So the first flow chart which I discussed here, this flow chart is for NEET exam, okay. NEET exam, they will not cross this flow chart, but this flow chart is important for INISET exam, okay. Here they can ask about KCO, okay. So this is one way of classifying the diseases, okay, one way of classifying the diseases, okay. So extra parenchymal KCO will be increased, okay, extra parenchymal KCO will be increased, and this is very, very important for your INISET exam, okay, INISET exam, okay. So very, very important thing, okay, very, very important thing for your INISET exam, okay. So now coming to a scenario which you're going to tell me the answer, okay. So we have few scenarios here. You tell me the answer for the scenario. So where KCO will be increased? Extra parenchymal. Where KCO will be normal? Intraparenchymal. Okay. What is the first scenario? So first scenario, TLC is 60%. What is the first step? Whenever you have any question, what is the first step? FE1 by FEC ratio. FE1 by FEC ratio is normal or increased. What is the second step? TLCO. TLCO is 60%. It should be a vascular pathology. Okay, vascular pathology. Next is RV. RV. What is the significance of RV? For first flowchart, you take the first flowchart. What is the first step? FE1 by FEC ratio. Here FE1 by FEC ratio is normal or increased. So what kind of pathology it is? It should be restrictive pathology. What is the second step? If it is restrictive in your flowchart, you have to see for RV is normal or decreased. What happened to the RV here? Decreased. Okay. So what should be the pathology? It should be intrinsic restrictive lung disease. So this is a case of intrinsic restrictive lung disease due to pulmonary fibrosis. Okay. What is the second scenario? FE1 by FEC is normal. DLCO is 95%. Okay. 95%. Then what happened to the RV? RV is increased. So what should be the pathology? It should be extrinsic restrictive lung disease. It should be restrictive lung disease due to some outside pathology. Okay. Next scenario. FE1 by FEC is normal. What happened to the DLCO? DLCO is normal. What happened to the residual volume? Increased. So what should be the pathology? FE1 by FEC is normal. DLCO is normal. Okay. But RV alone increased. Okay. RV alone increased. Okay. So what pathology you can think here? Extrinsic restrictive lung disease. Okay. Extrinsic restrictive lung disease. Okay. So this is actually a case of myasthenia gravis. Okay. So there is one more thing which we can add here, but I don't want you to confuse. Okay. There is one more thing, so I don't want to confuse this. Just see here DLCO, FE1 by FEC. Okay. Fourth scenario. FE1 by FEC decreased. So what is the pathology? OLD. What is the next step? See for the improvement. Improved or not? What kind of pathology? Asthma. What is the last pathology? FE1 by FEC decreased. Post bronchodilator improvement? No improvement. Reversible condition or irreversible condition? So what kind of pathology it is? Even if you can see the TLC is increased 130% TLC, RV is 310%. So what should be the case? It should be a case of emphysema. Okay, emphysema. Okay. So if you identify the scenarios, then you can go for the diagnosis easily. Even எதுவுமே தெரியல, nothing you are able to remember, just remember FE1 by FEC ratio. Okay, decreased or increased. Second is in restrictive lung disease, If it is going to be increased, then the next step is DLCO. DLCO is decreased or increased or normal. Okay. Based on this, you can make most of the questions correct. Okay. If you're going to go for advanced level, then you have to go for RV by TLC ratio and KCO. Okay. That is one important thing. Okay. So this is very, very important. Okay. Very, very important thing to know. Okay. FE1 by FEC is decreased in asthma. Okay. Asthma. DLCO is decreased in all except. It is decreased in all except alveolar hemorrhage. Okay. Alveolar hemorrhage. Okay. Alveolar hemorrhage. Okay. Okay. So what we have? Okay. So with this, we are finishing our physiology part. Just for your recap of your physiology. Okay. What is this law actually? It is Newton's third law, which says that for every action, there is equal and opposite reaction. Okay. The same concept can be used in something called compliance. Okay. Compliance. What is compliance? What is compliance? So in your physiology, they would have told you, they would have told compliance is equal to change in volume by change in pressure. Okay. Change in volume by change in pressure. Just just for your understanding, I'm writing, physiology, they would have discussed this. Okay. Whenever there is an increase in compliance, okay, it means that there is decrease in elastance. Okay, decrease in elastance. In which condition there will be decrease in elastance? Emphysema. Okay, emphysema. Here we have two types of compliance. Okay, one is called as static compliance. Another one is called dynamic compliance. Okay, static compliance means whenever, if this is a balloon, okay, I'm going to hold the balloon at this point and I'm going to see the change in the volume. Okay, whenever the balloon is an hyperinflated balloon, what will be the change in volume? Increased. Okay, the volume will be more. Okay, in that condition, the compliance will be increased. Okay, so in conditions like emphysema, static compliance will be increased. Okay, whereas whenever this balloon is twisted like this, okay, what will happen to the compliance? Volume decreases, so compliance will decrease. So static compliance will decrease in all kind of rigid lungs, okay, or restrictive lungs. Okay, that is static compliance. Okay, we have another one compliance. What is that compliance? Dynamic compliance. Dynamic compliance means whenever the air goes inside and comes outside, that change in volume is called as dynamic compliance. Okay, whenever I have an obstruction in the airway, okay, what will happen to the change which goes or which happens when air goes in and comes outside? Decreases. So any obstructive lung disease, dynamic compliance will be decreased, including emphysema. Okay, so in emphysema, already the balloon is too much stretched. Okay, when air goes inside, whether the balloon will be able to stretch further? No. Okay, so dynamic compliance is decreased in emphysema. So emphysema எடுத்துக்கிட்டீங்கன்னா static compliance will be increased, dynamic compliance will be decreased. Okay, so that is one thing in physiology you have to know. Okay, புரிஞ்சுச்சா? Static. Okay, static na, see இந்த balloon இருக்கு, இந்த balloon நான் வந்து blow பண்ணி வச்சிருக்கேன். Okay, when I blow the balloon too much, okay, and hold the balloon at the top, what will be the volume? Increase. So static இருக்கும்போது volume வந்து increased இருக்கு. Okay, so static compliance is increased. Okay, the same patient, the balloon is restricted. நான் இந்த மாதிரி கை வச்சு ஹோல்ட் பண்ணியிருக்கேன். இப்போ இந்த பலூன் வந்து இந்த மாதிரி ஒரு பொசிஷன்ல அதோட வால்யூம் எப்படி இருக்கும்? கம்மியா இருக்கும். Okay, so what will happen to the static compliance? Decreased. Okay, டைனமிக் காம்ப்ளைன்ஸ். டைனமிக் காம்ப்ளைன்ஸ்னா இந்த பலூன் இருக்குல்ல, இந்த பலூனுக்கு ஒரு எலாஸ்டிசிட்டி ப்ராப்பர்ட்டி இருக்கு. இந்த பலூன் நான் ரொம்ப நேரம் ப்ளோ பண்ணி ஒரு பாயிண்ட்ல வச்சிருக்கேன். ஓகே, இப்போ வந்து என்னன்னா இந்த எலாஸ்டிக் டிஷ்யூ இருக்கு இல்லையா, இது ஃபுல்லாவே போன பிறகு நான் ப்ளோ பண்ணா பலூன் பார்க்கறதுக்கு பெருசா இருக்குமே தவிர எக்ஸ்பேண்ட் ஆகுமா? ஆகாது. ஸோ வாட் வில் ஹேப்பன் டு த டைனமிக் காம்ப்ளைன்ஸ்? டைனமிக் காம்ப்ளைன்ஸ் மீன்ஸ் டியூரிங் மூவ்மெண்ட் decreased. So emphysema is one condition where static compliance is increased, dynamic compliance is decreased. Okay, so this is one important physiological difference between static and dynamic compliance in cases of emphysema. Okay, emphysema. Okay, very important difference to know in. So what is this one? This is a balloon. Okay, it is very slow. The balloon goes inside and expands. What is this called as? Dynamic compliance. Okay, whenever you have an obstruction in the airway, what will happen to the dynamic compliance? Decreased. Okay, decrease. Okay, including emphysema. Okay, emphysema. Okay, so this is one difference between difference in emphysema which you should note, and this is one question which is repeatedly asked in physiology. Okay, repeatedly asked in physiology. Okay, so with this we are finishing compliance. Okay, what should be the answer? Why? He is a man working in coal mining factory for 15 years. So what we should see usually, FeV1 by FVC ratio. What is the FeV1 by FVC ratio? Decrease. So it should be a case of obstructive lung disease. Okay, obstructive lung disease. Here the obstructive lung disease is going to be COPD. Okay, COPD. Goodpasture syndrome. Goodpasture syndrome is also called as pulmonary alveolar hemorrhage syndrome, right? So answer is Goodpasture syndrome. It should be timed. Okay, which measurement is preferred? Timed. So it is timed vital capacity. Residual volume is best measured by body plethysmography. In restrictive lung disease, FeV1 by FVC ratio is increased, compliance is decreased. Answer is D. It should be residual volume. Residual volume. It should be increase in FeV1 by FVC, decrease in RV, decrease in TLC. Increased VC is wrong. Okay, increased VC is wrong. Patient presents with decreased vital capacity and total volume. So it is not coming under ABC. What is the odd man out here? Sarcoidosis. Okay, it is a restrictive lung disease. Okay, restrictive lung disease. Pulmonary compliance is decreased in all of the following conditions except pulmonary congestion. Whether you can expand the alveoli? No. Decreased surfactant. Whether you can expand the alveoli? No. Pulmonary fibrosis, you cannot expand. So here answer is going to be COPD because they mean it is emphysema and they mean static compliance. Okay, they mean static compliance. Okay. It should be whatever it is, even if it is emphysematous lung or a restrictive lung, you have to go for body plethysmography. Answer is body plethysmography. It should be obstructive lung disease. Okay. So with this, we are finishing the physiology part of respiratory medicine. So till now, what we have seen is the anatomy part and physiology part. We have not entered into the core pulmonary medicine. Okay. So from here, everywhere, wherever you go, asthma, COPD, interstitial lung disease, sarcoidosis, or whatever disease you name, all investigations will have spirometry and spirometry pattern. On all questions in your MCQ, in whichever, even in app, if you are solving the questions, or in exam, if you are going to solve questions, everywhere they will have FE1, FEC, DLCO, and that will be the main thing to make lot of diagnosis in the question. Okay, so we'll go for lunch break. After lunch break, we will start with respiratory failure.